when you think about this, what are the thoughts which come to your mind when you think about surgical treatment? Do I know the pain generator? Is it the right patient? When do I offer a revision surgery? And what surgery do I offer? And when do I offer a fusion? The biggest question. And what are the chances of it succeeding? And I'll tell my take on this. So with this, we'll discuss about surgical decision in making a recurrent IVDP. Now, you should be very clear about what is the pain generator when you think about a revision surgery, because we heard all these things. What are the most common causes of pain after this surgery? Could be any of these or all of these in combination. Now, we heard a lot about the risk factors. Now, in this specifically, radiology features is that when you have a extruded disc with a large annular defect, meaning more than 6 millimeter in both planes, there is at least 1/5 chance of recurrence. So we should know this when you look at MRI. And remember, the annular prolapse with no disc herniation is got a high rate of recurrence. So always keep it in mind when you look at the MRIs and when you advise surgery for them. And intraoperatively, if you are an operating surgeon, if there are multiple fragments in an intact annulus, again there's a higher rate of recurrence as compared to a classical sequestrated disc. Now, if you look at this large series, if you see, real recurrence had a shorter interval from the index surgery. So the longer you go, it is not a real recurrence, it might be other associated features. So we should keep this in mind when you plan about the pain generator. Now, we all know, or we do all these things when you do the workup, dynamic x-rays. Did the initial surgeon do arteriogen lysis? Is there any listhesis present? And is there any so-called instability which is defined as more than 3 mm translation in the lumbar spine, more than 5 at L5S1, and do you have more than 10 degree of end plate angulation? We will not go anything more into it. We should be very sure with an MR Gado, and we should differentiate between a scar and the disc, hematoma, abscess, and the last one, arachnoiditis. If you do this, please don't offer surgery. It's going to be a headache for life if you ever have to do a revision surgery for this indication. Now, a lot of them allude as to, does a surgical technique has to do anything with, did you do a subtotal versus limited with the targeted fragmentectomy which is done today in endoscopic surgery? Do they have an increased recurrence? And does an open surgery have an increased recurrence as compared to microscopic? And did your technique of discectomy have a bearing of increased recurrence? So when you look at the literature, it says that there is no much difference between subtotal versus total versus open versus endoscopic. So this was a paper from the master himself, Sebastian Rutten, which did not find any increased recurrence because of endoscopy as compared to microdiscectomy. Now, this I'll not go any thing. I just heard Dr. speak on this. Now, when do you advise surgery? If you see a lot of the recurrent disc, it says that there is no. So they have got a very low rate of non-surgical treatment. 92% end up in revision surgery. So that means if you're taking it up, most likely you're going to offer surgery. Now, how do you proceed? If you ever have a Cauda-Equina syndrome, again, there's no question. You right away go ahead, no sitting and trying to find the pain generator. If you don't have a Cauda-Equina syndrome, then you really spend time and identify what is the real pain generator. And remember, it's always beneficial to offer surgery for a leg pain than a leg pain, back pain in a recurrent situation. Most likely you're going to offer surgery. Now, how do you proceed? When do you offer a revision discectomy alone? It is radicular leg pain with no instability on radiographs. And when do you offer a fusion? If you have any of these features, like a severe foraminal stenosis, you have instability, radiologic or clinical, and if you are the initial surgeon, or you know that there is more than 50% facet resection initially in your first surgery. When do you offer a now, this is very important. Whenever you offer a surgery, you should remember some technical tips about this. Remember to try to go lateral. Don't try to go and retract the root. Whenever possible, try to avoid root retraction. You might end up removing more, drilling more bone than your primary surgery. Be very careful in handling soft tissues because there's an increased rate of dural tears, and not just dural tears, dysthesias after you do a root handling in revision surgery. Avoid excessive retraction immediately. That's where endoscopy or minimally invasive comes in role. And please don't attempt it without appropriate magnification and illumination, microscope, endoscope, whatever you are familiar with. Please employ that so that you end up with less tissue retraction. And whenever you employ a fusion today, we know that TLIF has got definite advantages over a PLIF because we don't do any retraction. Now, these are the indications of using them whenever you go in for a second surgery. Leg pain with instability or deformity, severe back pain with leg pain, significant end plate changes on the MRI along with leg pain or a heavy manual laborer. It's a very common indication for me. And if there's a prior revision surgery, if he had one revision surgery for a disc, again you're coming for the third time, try to go and fuse it. Leg pain with now we all speak about all these instability features with dynamic x-rays, but remember it need not be over. Look at the MRI very carefully for these features. Look for facetal cyst, look for lateral listhesis, retrolisthesis, facetal widening, facetal effusion. These are features of subtle instability. So if you have these features, it's ideal or better to go and fuse them than going and just decompressing them. So is it good? Yes, the results are very promising. If you look at these results, a later review says that the current risk has got 58% chance of success. Remember, not as much as a primary surgery. Now, again, various things has been discussed regarding what are the indicator factors, but nothing has been, no surgery has been found to be better. Now, this was an interesting paper published in 2023, which looked at all the features of revision discectomy, which actually come out saying that the fusions offer to be better than just revision decompression in case of recurrent disc herniation. What's my preference? As the patient and the imaging, when I counsel them, I tell them that if it depends, it's my patient, my recurrence or somebody else's recurrence. If it's my recurrence, I know that I would have opened the lateral recess. So I choose more in terms of endoscopy there because I know I have opened up the bony canal. See for obvious surgery correctable causes, and if pure radiculopathy, then and no other risk factor, revision decompression alone. And when in doubt, fuse them. When in doubt, fuse them, because this is my take on it. Because and I typically do this. I do a uni TLF. I do same two port. I just decompress. I resect the facet and do this. So the take home, it's a most common complication. You have to define the type of herniation. You have to define the pain generator. Read the Gado MRI very carefully. Make sure it is not a scar. Fuse them. Revisions can be simple in a single recurrence and fuse when I'm in doubt. Thank you.